Fulton. I'm one of the clinical oncology consultants based at the Beatson in Glasgow, and one of my subspecialist areas of interest is in paediatric radiotherapy. So that's what we'll talk about today. In essence, as I'm sure you can appreciate, paediatric radiotherapy in itself is an enormous topic that traverses really the vast majority of paediatric malignancies, as well as a variety of different ways of using therapeutic radiation. So what we will try and do is deal with some of the more common paediatric malignancies that involve radiotherapy, talk about the types of modalities that we use, the sort of things that we think about. So when a child is referred or there's discussions around the role of radiotherapy, the sort of logistic issues, the sort of setup and planning and treatment delivery issues that we think about. And then at the end, we'll briefly touch on proton beam therapy and its role in managing some pediatric malignancies. Again, I'm conscious proton beam therapy in itself could be an entire talk all on its own. We will sort of touch on some of the principles, again, because there's always a little bit of mystery and a bit of intrigue around proton therapy, and we'll talk about both its benefits as well as its limitations, which are both significant. So again, just to touch on starting to think about radiotherapy, I'm sure you've all seen this. So this is the COG data that's now been, God, it's now 14 years old, but in essence shows the trends and outcomes of children diagnosed with cancer really since the 70s up until the mid-noughties, showing all mortality for all cancer sites. So the blue line in essence is the solid tumours, and then the gold line is due to lymphomas and leukemias. So encouragingly, a significant improvement in mortality from children diagnosed with cancer. But interestingly, that's not due to the use of more radiotherapy. So this is the same patient group. So again, the COG North American group that show for really pretty much all the tumour sites that we're used to seeing and treating, there has actually been an overall reduction in the number of children having radiotherapy treatment for pretty much each of the indications that we see. Likewise, this is the same for the other common indications that we see, so most of the hematological malignancies, as well as the CNS malignancies. So we see that there has been a steady reduction in the utilisation of radiotherapy over the years. And again, we'll talk about the reasons for that, which are fairly obvious, but are pretty evident. Whilst talking about radiotherapy, as we touched on at the start, there are many different ways of using therapeutic radiation treatment. In essence, the term radiotherapy is a fairly all-encompassing, fairly broad term. What we will talk about today is what we call external beam radiotherapy. Again, even within that, that encompasses photon and proton techniques, probably the ones that people are the most familiar with. It does also encompass the use of electrons, as well as heavy ion therapy. So for those of you that have read lots about radiotherapy, that includes things like radiocarbon ions, hydrogen ions, as well as neutrons, none of which are in current clinical utilization. So really the two techniques that involve external beam radiotherapy really are proton and photon delivery techniques. Photon radiotherapy being the one that we deliver here in Scotland, and proton's the one that is currently not delivered in Scotland, but is now available via UK commissioning for the past 3 years. It has involved children travelling abroad before that. We today won't touch on radionuclide therapy, things like MIBG, radiooctreotide therapy, scintigraphy, again, is a talk in of itself. And again, we won't go into detail about brachytherapy. Some of you may have read about AMOR, so the use of interstitial brachytherapy in head and neck cancers. And there are some indications for interstitial brachytherapy, particularly in vulval and vaginal rhabdomyosarcomas, as well as some bladder rhabdos. Again, we won't go into that today. It's a whole talk into itself, and we'll try not to keep you all day going on about it. So in essence, we'll talk about external beam radiotherapy, which really means proton and photon radiotherapy. The first thing that I'll just touch on, and one of the things that I'm conscious of, is that there may be some people that have been to the Beatson to see what radiotherapy actually looks like for a child coming here. There may also be some that hear a child's going for radiotherapy and that's sort of a black hole until they finish. So in essence, I just want to very quickly run through, you know, what the experience and what the steps are for radiotherapy for a child that's referred for treatment. So this is where we are, so the Beatson Cancer Centre in the West End of Glasgow, which delivers photon-based radiotherapy for children in the west and north of Scotland. For radiotherapy, there are a few stages involved in the process. There's really 3 major steps that a child will go through prior to starting radiotherapy. The first of which is to come to the Mould room. In essence, this is a little bit more of an art than a science, the Mould room, but it's really the way in which we look at how we immobilise a child for radiotherapy. So you can see in the very top left-hand corner, that's the very uncomfortable carbon fibre couch they lie on for radiotherapy. The top right-hand picture is a picture of actually an adult. I'm sure you could spot the legs, it's not a child. But that's actually an immobilisation device for a young adult looking to try and immobilise a limb extremity. And the 3 bottom pictures are 3 children that we treated, and those are the immobilisation shells that we use for them. So as you can see, for a child, it's a relatively intimidating experience. Particularly the shells can be a challenge, particularly for children that are awake. There are some children that don't require a shell, so they'll come to Mould room and we use what we call a vac bag or another immobilisation device, which are usually something that we try and do for children that are those that are asleep. We tend to put into a shell, mostly because they don't notice it when they're asleep. The older children and the young adults we tend to have in a shell because we can usually coach and manage them. The sort of in-between stage, the sort of 4 to 8 year olds, it depends a little bit on compliance, and there's sometimes a bit of a negotiation between how we immobilise them and what they tolerate. So ideally it's good if we can get a run-in for those needing treatment, which gives us time to work with play therapy and things to think about how we immobilise children. But that's usually the first consideration we have for any child coming, is how still they'll be, how they'll position for the treatment, and how they'll tolerate that position for what can be up to an hour on what you can see is a pretty hard, pretty uncomfortable couch. The next stage any child would have, so once they get their mould made, is then have what's called a planning scan done. So again, in essence, it just involves a fairly standard cone beam CT scan being done. Obviously, that isn't a dose of radiation for children, so that's something that we always look to minimise, and there are sort of specific protocols for the kids to minimise their total dose from the scan. But other than that, it's really just a scan whilst wearing whatever immobilisation device they'll be treated in. And it's the first chance that allows us to really assess, you know, their ability to tolerate that position and how long they can stay in that position, as well as actually acquiring the images. This is actually not a patient that we treated, it's actually a volunteer, so it's the son of one of our radiographers, just if you're wondering. This then is that same young person. So once they've had their mould done, we've established what position they can stay in. They've then had their CT scan done. They then get a couple of weeks off. We use all that time to map and design and plan their treatment, and then they come back to start. And this is that same young person lying on one of our radiotherapy treatment couches. Officially, it's what's called a linear accelerator, which really just means a high mega voltage, high energy radiotherapy delivery machine. So as you can see, this young boy is lying with a mask over his head. So this is a fairly standard position and setup that we'd use to treat any CNS or head and neck tumour. So things like medulloblastoma, ependymoma, DIPG, this is the sort of immobilisation to be looking at. And reasonably well tolerated in particularly older children, but as I'm sure you can imagine, for some of the younger ones, that position for 45 minutes is quite a big ask. But that's generally what to expect. So the image you can see on the right, that's the collimator of the machine. So the bit to the sort of top left, the sort of 11 o'clock position, that's the head of the machine where the radiation comes out of. That spins in a 360-degree arc around the child, but it never touches them, and they wouldn't feel anything when it's on. It sort of clicks as it traverses round them, but other than that, they wouldn't actually know the machine is on. And then obviously they do that generally once a day for a predefined period of time, a number of treatments depending on the intent of the radiation treatment. Now that you know roughly what a child expects. We'll come and talk about some of the role of radiotherapy in particularly common paediatric cancers. Again, all diagnoses you'll be very familiar with, and we've particularly will focus today on the ones where there is a significant role or debate about the role of radiotherapy treatment. So again, hopefully none of those diagnoses are overly unfamiliar with you. Because there's obviously a lot to discuss about radiotherapy, I deliberately will focus on the radiotherapy aspects of each of these diseases, again, because likewise each of them is a talk in itself, and I'm sure you'll have people much more expert at it than I to talk about it, a number of them. Is that okay? Was that somebody with a question, or was that a child in the background?
I think it was just a child, Ben.
Fair enough, just checking, just in case. Sorry, it's hard to see the comments. Bubu, can you or somebody let me know? Because on the slide, it will just let me see my presentation. It won't let me also raise the question. So if somebody does, can somebody just raise or shout a comment or something? I'm not ignoring you, it's just I can't see it at the same time.
No problem.
So the first of the tumour sites that we will touch on is Wilms tumours. So again, a fairly common diagnosis we are used to dealing with. The aims of radiotherapy in Wilms children, there are typically three major indications for radiotherapy, one of which is to achieve local control of abdominal disease in patients with a significant risk of intra-abdominal relapse. And we'll come on in a minute to clarify what we mean by significant risk of intra-abdominal relapse, which in essence is mirrored in the umbrella protocol. We also use radiotherapy to increase local control of pulmonary metastases. That's becoming an increasingly controversial area, an increasingly complex area. But in essence, currently it's those that have not achieved CR following chemotherapy plus or minus surgical therapy to their pulmonary metastases. And we also use radiotherapy to increase local control of other sites of metastases that may involve liver, bone, or brain metastases, again in children who didn't achieve complete response after chemotherapy, should really say plus or minus surgery. So there are a few indications in Wilms. The majority, so 80% of those that we treat are flank or abdominal radiotherapy, so it's that first of the aims of treatment. As we touched on, this is the excerpt from the current umbrella protocol, which again, I'm sure you've all seen plenty of times, which really talks about the risk stratified adjuvant management of Wilms. As you can see, the number of children over the years, as was shown in the initial slide, it used to be that all children with high-risk disease and all of those with stage 2 and above intermediate risk disease got radiotherapy, particularly through the 90s. But actually now the proportion of children getting adjuvant radiotherapy is significantly smaller. The majority of them getting flank or abdominal radiotherapy are generally those with stage 3 disease, with the exception of those with low-risk stage 3 disease. We don't see very many stage 2 high risks that get adjuvant radiotherapy. So the majority of them are those with stage 3 disease. So, generally either positive margins, residual disease, or node positive disease are our commonest indications for flank radiotherapy. Those that have intraoperative rupture of the tumour, there's also discussion about the role of whether it's flank or whole abdominal radiotherapy. Again, a very controversial area that we'll come on to. The other indications in metastatic disease, again from the umbrella protocol, we tend to treat in terms from a radiotherapy perspective. We tend to risk stratify the local radiotherapy, so the abdominal primary based on their local stage. So again, the indications of that are generally the same. So those with local stage 3 disease or high risk non-blastomal stage 2 disease would get flank radiotherapy. And as we touched on before, the current umbrella protocol guidelines, which were only published at the turn of this year, so it used to be that all children with lung metastases would get radiotherapy. Now those that have a CR or that have a CR and surgical resection of their metastases can avoid whole lung radiotherapy. Again, not that common, only about 10% of the children that we treat will need whole lung radiotherapy. The majority of what we do is flank or abdominal radiotherapy. There is always a bit of a debate, and you'll probably see through Tumour Board, one of the queries with radiotherapy in Wilms is all about timing of radiotherapy. That is based on a study produced by Debbie Stokes in America, which was based on the NWTS, so that's the COG Wilms studies 3 and 4, suggesting that there was an event-free survival benefit by starting radiotherapy within 2 weeks of surgery. As I'm sure you can imagine, given that the indications for radiotherapy are defined by a pathological classification from a logistic perspective, that's obviously very challenging, given that we need a pathology report, they then need to come for a planning scan, then need to plan their treatment, and then start. All of that within 2 weeks is extremely challenging. Dan Saunders at the Christie, who is the lead for the Renal Tumour Advisory Group, produced data last year showing that the average in the UK is about 4.5 weeks from surgery to starting the radiotherapy. There is a bit of debate about how relevant it is starting with 2 weeks, and I'll show you that in the next slide. The other things that we have to think about in terms of timing of radiotherapy is particularly those children that need both whole lungs or another site alongside their flank treated. The controversy around that is that if we try and start the flank treatment within 2 weeks, it can then be very hard to treat the other site at a later date. So trying to do all of it within 2 weeks is very challenging. So we always have a debate and I think about whether we treat them sequentially. So whether we treat the flank within 2 weeks, which is where the evidence base for the event-free survival comes, and then treat the lungs later. But there is a worry then about a risk of overlap between the two, or the positioning being different in the time in between, or the other option is treat them at the same time and accept that you won't start within 2 weeks. So again, that's always a bit of a debate, and again, we'll come on to that in a bit. The other thing about timing of radiotherapy with Wilms is that we do need to avoid overlap with radiosensitizing chemo agents. The two that particularly for us are an issue are either doxorubicin and actinomycin D, both of which are radiosensitizing. Doxorubicin, the data shows that it increases your risk of cardiac toxicity by starting radiotherapy within 21 days of dox. And actinomycin, depending which protocol you follow, there should either be a 10 or 14-day gap between actinomycin dosing and radiotherapy. Again, simply because it's a radiosensitizer, so may increase your toxicity with radiotherapy treatment. The timing of radiotherapy, so this is the Kaplan-Meier curves of overall survival, which is based on the Stokes paper that was published, which is the kind of a retrospective analysis of the COG NWTS 3 and 4 studies. So the top left curve is the overall cohort. So the blue line is children that started within 14 days of their operation, and then the gold colour is those that started out with 14 days. And as you can see, there is a small separation in those survival curves. The second top right one is, and the bottom one are breaking them down into those with localized disease. So the top right-hand corner is those with just flank radiotherapy. The bottom is those with metastatic disease. In essence, there's an awful lot of debate about this, but the overall consensus, particularly in the UK, is that this is a retrospective series with an awful lot of bias to it, and that patients starting within 14 days generally have made a good functional recovery. If you look at their average tumour volume, it was about 60% less than those that took more than 14 days. And there was a greater risk of surgical complications in those that took longer, as you would sort of expect. So in essence, there is an awful lot of bias to this as to whether that is a true effect of the radiation treatment. The majority of radiotherapists in the UK don't truly believe that it's due to the effect of the radiotherapy that makes the difference in that survival, but it has led the current umbrella protocol and the current UK recommendations to be to start as soon as is physically possible. So in essence, that means as quickly as you can get the pathology report, see the child, tee them up for radiotherapy, and then get started. So again, as we touched on, Dan Saunders demonstrated that in the UK that is usually just over 4 weeks. It's very rare that we actually manage to start their treatment within 14 days, though it's something that we aspire to be as close to as we can. In terms of Wilms doses of radiotherapy, there are unfortunately a huge spectrum of them. The current umbrella protocol is the UK EURTC collaborative approach to dose, which is very different to the COG approach in the States. So this is what we use in the UK. So those children with stage 3 intermediate risk disease get 14 gray of radiotherapy. They get a boost if they have residual disease, but if they were just stage 3 in the basis of node positivity, they get 14 gray of radiotherapy over a week and a half. Those with high risk disease, so that's stage 2 or stage 3 non-blastomal, so the blastomal type don't get radiotherapy, out with positive margins, they get 25 grays. They do get dose escalated treatment, the feeling being that they are at higher risk of local relapse. The doses, if we do it, which we very rarely do to metastatic sites, are in essence, they get very focal radiotherapy. So we just treat the area where the metastasis is with a very small margin around it. And again, there's a variety of doses between 15 and 25 gray. Again, I highly doubt you're ever going to need to know that. We do it very, very rarely. And again, they're all fairly well documented in the current umbrella protocol, but actually there's very little evidence base behind them. They in essence are just what has been historically done for a very long time. This is an example of a child that we in Glasgow have treated for Wilms tumour. So this is a patient who had an intermediate risk stage 3 primary abdominal tumour, as well as lung metastases with a non-complete response. So what you're looking at is here. So the left two are axial images, and then obviously you've got a corona on a sagittal picture. This is a boy who is positioned in the radiotherapy treatment position. So if you look at the top left picture, you can see that sort of light grey line that's draping over the top of his skin and then goes down either side. That's the mould that we showed you earlier on that he's positioned in. He is asleep. And his arms are abducted high above his head, in essence, so that we don't have to treat them with radiotherapy, because obviously the overriding principle is to try and treat as a little of a child to as little a dose as we possibly can get away with. Sadly, because he has lung metastases and in intermediate risk stage 3 primary, we do have to treat all of those involved sites. So it does end up being quite a lot of radiation treatment. So what you're looking at in terms of the blue and the yellow bits with the bits of green in between, that's the radiotherapy planning scan. And what's been done, as you can see on each of the pictures, a sort of red line around his flank and abdomen. That's what we call a planning volume. So that's the target that we have delineated that we want to treat, which is the area where we feel he is at risk of recurring. And then the pink ones at the top are, the outline of his whole lungs. The blue colour is what we call an isodose. So that's a sort of modelling, so a predicted model of the radiotherapy dose to that structure. So the blue colour equates to around about 15 gray, which is the dose that we give to whole lungs. And the sort of yellowy, slightly greeny colour equates to the 25 gray isodose. So this shows that he's getting around about 25 gray to that whole lower abdominal primary mass, and then 15 gray of radiation treatment to the whole lungs. In essence, this reflects why we often try to treat them at the same time, because if we treated this child's flank and then came back later to try and treat his lungs, there would be an overlap between those two, which can be very difficult, because it then means you've got an area of either underdosing or overdosing, where you try and junction between those. So in general in Glasgow, when we have patients with metastatic disease that need treated above and below the diaphragm, we would usually delay doing it and do them all at the same time. So that would be once they've finished their doxorubicin, and unlikely to be within 14 days of an operation. But on balance, that's preferable to either underdosing or overdosing, that junction in between, which is obviously where his heart, esophagus, and spinal cords sit. So generally not an area we would want to over or under treat if we can avoid it, in terms of late morbidity.
Yeah, sorry, Ben. Just a quick there's just a wee question in there just now, if that's okay.
Yeah, of course.
It just relates back to your slides about starting radiotherapy within 2 weeks of the surgery. So one of the questions is just asking, does starting within 2 weeks impact on healing or local issues compared to starting later?
So again, a very good question. In general, not. We tend not to see particularly wound healing issues as long as, I mean, the initial assessment before they come for a planning scan with the surgeons is, once they're happy their wounds have healed, then they come to us to get started treatment. So usually by the time they have their planning scan and then start treatment, they're usually, a month down the line, and most kids are usually healing pretty well by that stage. We don't tend to see much acute wound breakdown with modern radiotherapy techniques. Most of the reason for that is that you can look at if you look at the very top picture, so the very top left-hand one, that's what we call the isodose of the radiation, sort of dose delivered to this child's abdomen. And as you can see, the vast majority of that dose actually sits posteriorly, whereas kidney sits. The majority of these kids will have an anterior approach for their surgery and for their wound, obviously not exclusively. So we tend to see that the area where they're healing tends to be actually paradoxically away from where most of the radiation treatment is. And with modern radiotherapy treatments, you tend to get what's called a skin sparing effect. So again, if you look at the image on the very bottom left, that's the isodose around this child's lungs. And if you look at the sort of light green in the outside is the sort of external mark of their body. And then if you look at it, there's a sort of an area underneath that that's kind of a light grey colour where actually there's pretty much no radiation dose getting to. So actually the dose that we give to skin nowadays with modern treatment is very low. It used to be much higher with what we call cobalt radiotherapy machines, which sort of stopped being used in the 80s. But nowadays, actually, skin reactions are not that pronounced, and particularly skin toxicity and local healing is generally not an issue that we see very commonly.
That's really interesting. Thanks a lot.
Move on. 2 seconds, just jumped between teams and the slides. So the next sort of commoner tumour site that we see sticking in the abdomen is children with neuroblastoma. Again, another common one that you'll all be very used to dealing with. A lot of children you'll see coming through. Rarely, if ever, do we use radiotherapy in those with lower intermediate risk disease. In children with neuroblastoma, radiotherapy is nearly exclusively used, and by that I mean external beam radiotherapy is nearly exclusively used for those with high risk disease. The evidence base for that is actually quite interesting and is actually very sparse, but it really comes from the CCG 3891 study that showed that children that had, so it was a randomization between 10 gray of radiotherapy given prior to conditioning for an autograft, and then either TBI conditioning or chemotherapy conditioning, and it showed a significant reduction in local failure. So those having chemo conditioning had about a 50% local failure. Those that had TBI conditioning had 20% local failure. It was statistically significant, and that was a study that was done in the 90s and was published in the early noughties. The evidence base, other than that radiotherapy is genuinely advantageous, local control, there's never been a randomized study. There now probably never will be. In essence, because these children did badly, it's been added to the overall package of the treatments. Like most things, it just steadily keeps escalating. But actually, Mark Gaze wrote a very good paper about 18 months ago now, running through the evidence base for radiotherapy. And because it's been established in the protocols for so long, actually the evidence base behind it is not all that robust. But it does form part of consolidation. Again, I'm sure you'll get plenty of talks about treatment of high-risk neuroblastoma, so I won't insult your intelligence by most of it. But the radiotherapy is a very small bit, post-myeloablative chemo, consolidation with radiotherapy, prior then to post-consolidation, differentiation therapy and immunotherapy. So radiotherapy is just a little box in the middle of that whole package of therapy for these kids. The radiotherapy for neuroblastoma is actually quite straightforward. It's sort of one of the easier things that we do from a radiotherapy perspective. The target volume and the bit that we treat really is, so it's not the extent of disease that they start with. What we treat is the disease that they had at the end of their chemo. the disease that they had right before their operation. So generally, we would usually be seeing these children after their operation, after their high dose. So what we have to do with the radiotherapy planning is to try and take a few steps back and treat where their disease would have been prior to their surgery and prior to their high dose, which again becomes a bit more of an art than a science sometimes, because that disease isn't there anymore. But not uncommon. That's the nature of radiotherapy, is treating a tumour bed. So the standard dose for neuroblastoma has stayed the same for a very long time. It's 21 gray and 14 fractions. So that's once daily over 3 weeks, or just under 3 weeks. The IMAT study that some of you may have seen, there was a patient in Glasgow randomised to it, used what's called a dose escalation. So by using modern radiotherapy techniques, randomised between an escalated dose of 36 gray and 20 fractions, again once daily over 4 weeks, versus the conventional treatment. The premise of that is that that should hopefully now be one of the randomizations for the HRMB2 study when it finally opens. But obviously there are a few steps away from that just now. But in essence, other than that, the radiotherapy hasn't changed for a very long time. One of the things that we often think about with radiotherapy in this setting is that the AMBL study, so what we talk about is OAR constraints. So what that means is organ at risk constraints. So those are particularly the organs in any child or any patient that we are worried about the radiotherapy toxicity to. Those are the figures from the AMBL study. I appreciate they probably look a bit alien to you, but in essence, what they are is they are very conservative dose estimates of how much radiation we can give to specific structures. So the things that we particularly focus on are both kidneys, the liver dose due to risk of veno-occlusive disease, and the lungs due to risk of pneumonitis. The lungs is generally not an issue for most of the intra-abdominal primary tumours. It is for some of the thoracic neuroblastomas that we see, and particularly the reason that those dose estimates are very conservative is because radiotherapy comes after high dose, which generally involves busulfan melphalan, and busulfan is a significant radiosensitizer. Particularly in the chest, there's a significant increased risk of fatal pneumonitis with radiation after busulfan, which is one of the reasons that there's always that debate in the Ewing's patients about the contrasting priorities of high dose and local radiotherapy. The dose in neuroblastoma is low enough that we can get away with it, but we have to be very tight with the constraints and the dose that we give to those organs as a result. So again, that's always something that we think about. But in general, because the dose is quite low in neuroblastoma, we generally get away with it. And the IMAT study escalating the dose has not shown a significant increase in toxicity. So the feeling is that it is safe. This is the radiotherapy plan for a child that we treated a couple of years ago now with neuroblastoma. So again, what you can see on the left is the axial, coronal and sagittal images of this child's radiotherapy plans. This is a child that's had their mould done, had their plan done, and this is them about to start their treatment. Again, that red area is the area that we've marked as their risk of recurrence, so the area that we want to try and give the full dose to. The red colour means that it gets 21 grey, which is the prescription dose. The green and the blue then are decreasing doses away from that. The image on the right is the same patient at the same level, but what it is that's using a different way of giving the radiotherapy treatment. So that's using, the one on the left uses a technique called IMRT, which means it uses a kind of continuous arc that rotates all the way around the child and gives us a gradual dose of radiation treatment all the way around that circle. The one on the right is a slightly more traditional way of giving radiotherapy, where you just give it from the front and the back in a straight line. So you treat the child from the front, the beam spins around 180 degrees, and then treats them from the back. The reason that's relevant is because the plan on the left, you may need to believe me in this, but there's more of the thing that we worry the most about with radiotherapy is their contralateral kidney. In general, a lot of these kids will have had a nephrectomy or have a poorly functioning ipsilateral kidney, so it's less of an issue. But given the amount of therapy they have received and will still need to receive, we are concerned always about the dose that radiotherapy gives to their other kidney in terms of radiation-induced nephritis. So the thing that we always prioritise is how we can minimise the dose to that kidney. The left uses, as I said, a modern ARC technique, but actually in this individual patient, that was actually worse than the one on the right, which is the more traditional way of giving radiotherapy. Part of that is really just because of the position of the child and where their tumour sat. So actually we used the one on the right, the plan to treat them, which is a more traditional way of giving radiotherapy. The advantage being that there's a higher proportion of the child. So if you look kind of where the red sort of oval shape is that we want to treat, there's a higher proportion of the child getting a medium dose of the radiotherapy, so that's a green colour in front of them, whereas in the plan on the left, there's less of them getting a low dose of treatment, but the contralateral kidney, so that sort of dark blue line, is getting more treatment on the left plan than it is on the right one. So that's the sort of compromises and the sort of things that we think about in intra-abdominal tumours. In essence, that's a fairly niche thing, but it's again just to show that there's not always advantages in some of the more modern technologies. We would always plan patients using both techniques. So all children would be planned using both, and then we have a sort of fairly detailed meeting and discussion about which of them is better for that individual. So often when we meet a child, it's one of the similar considerations we have with protons. It can be difficult to try and predict exactly what is the best technique to deliver treatment for that child. Again, sometimes it is an iterative process and requires you to plan it and look at it and see what you end up with. So sometimes it can be challenging from the off when you meet a family to know exactly what technique we'll use to deliver it, which again we'll come to with protons is of even greater significance. Other than that, neuroblastoma radiotherapy is pretty straightforward, really. The next tumour site we'll touch on, which has slightly more interestingly evolved over the years, is radiotherapy for Hodgkins. As I'm sure you'll be aware, historically, radiotherapy used to be treated with very large fields of, Hodgkins used to be treated with very large fields of radiotherapy, using what was called total lymphoid irradiation. And then the image on the right there is a sort of sagittal diagram showing, a sort of coronal diagram showing an adult patient having total lymphoid irradiation. So the sort of shaded, checked black lined area is where we aim to deliver the radiation dose to. So you can see it treats all of his neck, mediastinum, axilla, retrocardiac, mediastinum, abdominal, and groin lymph nodes. That used to do so to a dose of 44 gray in 24 fractions. So a fairly high dose of radiotherapy to a fairly large volume, especially in children. In Hodgkins, that used to have a very good high local control rate and used to give very good disease control. But as I'm sure you can appreciate, there is a very significant price for that, particularly in terms of late toxicities. So the majority of those were cardiac or vascular, secondary malignancy, sterility, as well as anomalies in the MSK system and bony and soft tissue growth and development. So this reflects the changing paradigms with Hodgkins, and that really this quite complicated log rank curve shows children treated with Hodgkins, and particularly the most significant of this are years since diagnoses and looking at both cardiac disease and secondary malignancy. And actually within 30 years of the end of treatment, your risk of secondary malignancy greatly outweighs your risk of relapsing and dying with your Hodgkins. Likewise, your risk of cardiac disease is nearly half of that of relapsing and dying of your Hodgkins at late toxicities, which is why a number of Hodgkin studies, the longer we follow children up for, actually show that the survival curves, despite event-free survival and 10-year survival being significantly better with radiotherapy, those curves actually steadily close together over the years, really due to deaths from secondary malignancy and cardiac disease. This is the plots looking at cumulative incidence of secondary malignancy from radiotherapy. So this is patients treated for Hodgkins who were either young adults or children at diagnosis. And really what it shows is it shows three different ways of giving radiotherapy and the population risk. So the grey dotted line at the bottom is the population risk of cancer. The gold one at the top is what's called mantle field radiotherapy, so treating the upper mediastinum and heart. The blue line is treating mediastinal radiotherapy alone, and then the red dotted line is the mantle field and pelvic radiotherapy at the same time. As you can see, there is a significant cumulative increased incidence of secondary malignancy. The thing that's quite interesting about this curve, this line, is that the mantle field and pelvic field treated together have a significantly lower late malignancy risk than the mantle field on its own, which often seems a little bit paradoxical. But actually, when you look at the cumulative incidence of the solid malignancies, the rationale for that is that the highest prevalence of secondary malignancy is in breast cancers. So actually the mantle field, with also treating the pelvis, partly because it causes hypoestrogenic state, so it puts women into early menopause, it actually reduces your total lifetime exposure to circulating estrogens, so actually reduces your risk of breast cancer relative to not treating your pelvis. So paradoxically, the risk of secondary malignancy is actually, it's still greater than the population baseline, but it's less than it is with just treating in women, treating the mantle field on its own, which I appreciate does sound a little bit odd. So the natural question, particularly given the significant late toxicities in Hodgkin's, there was obviously interest in looking at, can we safely omit radiotherapy, and particularly in children and young people with Hodgkin's. One of the things that is important to stress is that Hodgkin's is managed very differently in adults and children. So just to be clear, this is us talking about the management of Hodgkin's in children and young adults only, because it is quite significantly different. This is data that comes from the AHOD 0031 study, which is a phase 3 study by the COG group, so the North American Children's Oncology group, looking at the treatment of children and young people with intermediate risk Hodgkin's. So just, you may know this already, but the RER stands for the rapid early responders, and the SER stands for the slow early responders, which is the American classification for what we would call an adequate or an inadequate response to an ERA PET scan. The criteria were slightly different in this study, but in essence it's the same sort of concept. So this study, the curve on the left-hand Kaplan-Meier curve, it really just shows the crude overall survival. So looking 9 years out from treatment is excellent. So we know 98% of children and young adults treated for intermediate risk Hodgkin's were alive, and the majority had an event-free survival. Even those that relapsed, the difference between event-free and overall survival reflects the fact that there are very good relapse therapies for Hodgkin's. And looking purely at the overall survival and event-free survival in the rapid early response group, so those that had an adequate response were very good, so that event-free survival of 87%, and as we'd expect, those having what we'd now call an inadequate response have a poorer event-free survival. So the question in this study raised was, in those that have an adequate response, so a rapid early assessment, rapid early response, and a CR, can we avoid radiotherapy? At that point, it was what's called involved field radiotherapy. Again, we'll come back to the difference between the radiotherapy delivery techniques, but actually it showed excellent survival. So your overall survival, whether you had radiotherapy or no radiotherapy, in essence was the same between both groups. So that's this curve C. So the Kaplan-Meier curve on the right of those three show that those two blue lines overlap pretty perfectly. And then if you look at the event-free survival, involved field radiotherapy, so the more solid gold line, and those that didn't have involved field radiotherapy, despite the event-free survival being very slightly different and very slightly higher in the radiotherapy arm, actually those curves come back to meet each other a number of years later, which again reflects the excellent salvage therapies in Hodgkin's. So this is what led to the advent of Uranet C1 and our current standard of care in the UK, trying to select patients who don't need radiotherapy. These are the two studies that we're probably more used to looking at in the UK. So left is the trial schema from Uranet C1 that you're probably already used to, and in essence now this really forms the standard of care in the UK for children and young adults with Hodgkins, and the trial schema on the right is the current design for the Uranet C2 study. So in essence, the priority in C1 was looking at early stratification for radiotherapy, so divided into TG1 to treatment groups 1 to 3, with increasing stage of disease, but looking at in each of those patients doing an ERA, so an early response assessment PET after 2 OEPA, to stratify either adequate or inadequate response, which dictated whether they got radiotherapy or not. Currently, that involves what we call modified involved field radiotherapy. I'll explain what that means. But in essence, it really meant that you either got radiotherapy or you didn't. So it was a fairly binary thing. So that's what's called a risk stratified approach. So you can try and select patients whether they get radiotherapy or not. The major criticism with Uranet C1 and the question that they look to answer in C2 in terms of radiotherapy is looking at not just a risk stratified approach, but also looking at what we call an adaptive radiotherapy approach. So not looking at just do you get radiotherapy, yes or no, but can we select patients better for radiotherapy? So for example, if we did a further PET scan after either COPDAC or DCOPDAC, so doing what we call a late response assessment PET, can we further select some patients who then don't need radiotherapy at all, or need a lower dose of radiotherapy, or need a smaller volume of radiotherapy treated? So that's the premise of C2, is looking at can we better select not just who needs radiotherapy, but better defining exactly what radiotherapy do those individuals involve. Again, always looking at that premise of trying to reduce the late morbidity of radiotherapy without compromising outcomes. C2 also draws on some of the newer concepts of radiotherapy, which we'll touch on in the next slide. And that, as we touched on, so C1 used what we call modified involved field radiotherapy. So these pictures that come below show, so the image on the left is traditional, what we call total lymphoid irradiation. So that's what used to be used back in the 70s. So it means that the little black lymph glands are, for example, if you had Hodgkins in your neck, the treatment of radiotherapy would be to treat that entire area. So everything that's under that sort of dark grey shaded box, even if you start with a small lymph node in your neck, you would get radiotherapy to that entire volume and the inherent morbidity from it. We then move to what we call regional field radiotherapy, which is what's the second image from the left, which is a bit like a mantle field, which means because your disease is above the diaphragm, you treat with radiotherapy, you treat every lymph node above the diaphragm. Uranet C1 used the second from the right image, which is what's called modified involved field radiotherapy. So it means that, for example, if you have a lymph gland in a cervical node on the left side of your neck, you treat all of the cervical nodes on that left side of your neck. Or for example, if you have a central mediastinal node, you treat all of the mediastinum. Or if you have a paraortic node, you treat all of the paraortic nodes, but you don't necessarily need to treat all the lymph nodes around that area. And that was the established practice in Uranet C1. And then the image on the very right-hand side is what has been proposed for one of the subgroups in Uranet C2, and is the increasing trend. So actually looking at if you had an involved lymph node, we use what's called INRT, so involved nodal radiotherapy. So it means that rather than treating huge volumes of nodal chains, it means that we actually just focus radiotherapy on the ones that were PET avid and the disease that they had on their LRA, so their PET scan after their COPDAC or their DCOPDAC. So there's been a significant change in the volume of radiotherapy over the years. The doses are not dramatically different. They've been fairly fixed for most of that time, but we know that the morbidity of radiotherapy correlates with age of the patient, the dose given, as well as the volume that we treat. So the overall premise in C2 is to look to adapt radiotherapy more to an individual and to try and reduce the amount of radiotherapy that children and young people receive. This is an example of a young lad that we treated now a couple of years ago, who was actually treated in, more than a couple of years ago now, actually, but 5 years ago, who was treated as part of C1. So this is what we call modified involved field radiotherapy. So he started with disease in one axilla, one side of his neck, his mediastinum and para-aortic node, which meant we had to then treat all of those disease sites. If he was randomised in C2 now, that would end up being around about 10% of the volume that we treated back then. So it is a very significant reduction in radiotherapy. Obviously, because C2 hasn't reported yet, it's an open study that's relatively recently opened. We don't yet know the outcomes of that. There are a number of technical challenges to giving radiotherapy in that sense, in terms of these are generally lymph nodes that have disappeared, especially if they've had a good response in terms of size criteria. So from our perspective, this throws up some technical challenges, but you know, all very surmountable things if it reduces. In terms of the dose of radiotherapy, sadly, particularly in C2, there are 9 possible doses of radiotherapy that you can draw. C1, the standard dose of radiotherapy is 19.8 gray and 11 fractions. With or without a boost to residual bulk disease of 10 gray in 5 fractions. So I wouldn't worry too much about trying to know many of the doses in Euronet C2. It is complex. So the sort of take-home messages in Hodgkins are that although it is an extremely radiosensitive tumour, the doses of radiotherapy, particularly the target volumes, have steadily come down over the years due to concerns of late effects. It does remain part of therapy for some children with Hodgkin's, but really on a risk stratified basis. And we're hopeful of also that becoming a risk adapted basis rather than just risk stratified. There are attempts further to reduce, as we touched on, the radiotherapy indications, dose, and particularly total volume treated, which is one of the questions being asked in C2. The next tumour site we'll touch on are another one where there are some interesting controversies around radiotherapy, and this is children with Rhabdomyosarcoma. In essence, there are actually very few good studies looking at randomizations of radiotherapy in terms of local control in rhabdo. The last major study was the IRS IV study, which really has become the gold standard local control in both metastatic and localized rhabdo, so between IRS III and IRS IV, which again is the COG, so it's a North American approach study. All of these children, as you'd be very used to, get treated with risk stratified chemotherapy. So as per the EPSSG 2005 protocol, they get allocated to a risk grouping based on a number of features, particularly whether they're embryonal or alveolar, presence of nodal disease, IRS resectability. They get allocated a risk stratified group and get risk stratified chemotherapy, which I won't go in much detail about. But in terms of the radiotherapy alongside that, children with stage 1 and stage 2 disease, in general, if they have an embryonal tumour with an IRS I resection, can avoid radiotherapy, particularly very little children. It's not that common that we see those, but the commoner ones are particularly the botryoid vaginal tumours. There are a proportion that can get away without any radiotherapy. Some of them may need radiotherapy if, for example, they have an unresectable primary, so even still stage 1 or 2 tumour, but if it's unresectable, or if the feeling is that resection would have an unacceptable level of morbidity. Those children may require radiotherapy for their local control. That would currently be one of the proton beam therapy funding indications. So those with localized rhabdo are on the eligibility criteria for protons. Those with stage 3 disease generally will all get radiotherapy unless they have absolute contraindications or extremely little children that have had an excellent chemo and a good operation. Again, there are varying doses, but currently the IRS IV study was 41.4 gray over 5.5 weeks or 5 weeks. And in stage 4 disease, this is a little bit more controversial. The premise of radiotherapy we'll come and have a talk about, but the IRS study did randomise between 50.4 gray and what we call hyperfractionated treatment, so dose escalating, but showed no difference in outcome. So for stage 4 disease, the aim is to try and give 50.4 gray to their primary and in essence treat as much of their metastatic disease as is technically possible. We'll come on to that and what I mean by that in a bit more detail later. The first question that comes, particularly in young children with rhabdo, is can we safely omit radiotherapy? This table compares the two major studies. So MMT is the malignant mesenchymal tumours group. So this published in 1989 and then again in 1995, which is part of the CEOP, so the European group of treating rhabdomyosarcomas. And it compares the IRS IV study, which is the intergroup rhabdomyosarcoma group, which again is part of the COG North American. So the table on the left compares through the 80s and 90s what was the European approach, and then through the late 90s what has been the American approach. The major two difference between those approaches is that the European approach looked to reduce the amount of radiotherapy. So those in the MMT 89 study, 55% got any radiotherapy. And in the IRS IV study, 95%, so the vast majority got radiotherapy to both their local site and distant metastases. As you can see, the overall survival and event-free survival, looking at the total numbers, was significantly higher. So your total overall survival was 13% higher in the IRS IV study, and your event-free survival was nearly just over 20% higher in the IRS IV study. And when you break that down for subtypes, particularly the alveolar patients, it appears that radiotherapy for local control becomes increasingly important. It is still important for the embryonals, but just more so for alveolars, and is likewise equally important for particularly head and neck and orbital tumours. But really across all groups, radiotherapy is an important modality in terms of local control. The IRS IV study also looked at what we call hyperfractionation. So it looked at trying to escalate the dose of radiotherapy in this patient group, so giving it twice a day. Really, as you can see from the Kaplan-Meier curve, it made no real difference. So the standard radiotherapy dose remains in the IRS IV study, 50.4 gray to primary disease site, and again we'll come and touch on the dose to metastatic sites in metastatic patient group. IRS IV was a study in localized disease, IRS III was metastatic disease, so the hyperfractionation question was in those with localized rhabdo, showed no difference from dose escalation. The other controversy is probably a safe way to say that comes around rhabdo and radiotherapy is the timing of radiotherapy. Again, each of these come from the IRS IV study, really because it was the seminal paper on this disease. Those with low-risk disease, their radiotherapy tends to be at week 12. Those with high-risk disease at week 22. Those with intermediate risk, there is a little bit of controversy about, which we will come on to. The absolute evidence for either 12 or 22 weeks in the high-risk disease site, the major reason for that is to allow time after finishing doxorubicin, is the rationale for it in the high-risk disease. This is a paper that was studied in the paper that was presented in the Red Journal, about 10 years ago now, that looked at the timing of radiotherapy for intermediate risk rhabdo and frightened a few people. In essence, this compares two different studies. So one is the D9803 study, which actually was a randomization between VAC and VT therapy. So VAC versus the addition of temozolomide instead of actinomycin, which gave radiotherapy as part of their protocol at week 12. And then that compared it to the IRS IV study, which just had VAC as its standard. As part of that, when we look at the proportion with local failure, there seemed to be some late local failures in those treated at week 12 within the D9803 study. There is quite significant debate around that. They were different studies with fairly different patient groups. Their classification of low and intermediate risk were different, but there is an argument that should we try and do radiotherapy as early as possible, and is there a local control advantage with starting early with radiotherapy? The honest answer is we generally don't think there is in the UK, but in America they will now treat on week 4. So children with intermediate risk disease, rhabdo, will get very early treatment alongside their VAC chemotherapy, which is slightly different to what we do in the UK. So we still aim to treat at week 12, but there's always that nervousness about can you delay much beyond week 12. I personally don't believe it's a big difference. I think it was just the difference between the two studies that they pick up those late relapses. But again, there was also a higher proportion of alveolar patients in the D9803 study, so there are limitations to that comparison. But there certainly is, safe to say, there is controversy around the optimal time. In general, it shouldn't be too far beyond 12 weeks for intermediate risk rhabdos. As we touched on, there is a lack of high quality evidence around a number of the radiotherapy questions around the management of rhabdo. It is now standardised in the EPSSG 05 protocol, which is our standard of care in the UK. But what you're seeing there is the trial schema. Some of you may have seen this already for FARMS, the FAR RMS study, which is going to be the next UK platform study for frontline and relapsed rhabdo, actually has 2 very, very interesting radiotherapy randomizations. So as I said, there are chemotherapy randomizations, there are maintenance therapy randomizations, and there are relapse randomizations. The one that I will selfishly focus on is the radiotherapy 2 randomizations. And this is what they look like. And in essence, this is a very complicated flow diagram, but in essence, what it's really looking at is children with localized rhabdo, looking at are they better served by having preoperative or postoperative radiotherapy? So that's the first randomization. And the second randomization is looking at, in those with a higher risk of local failure, looking at giving an escalated dose of radiotherapy. So each individual child can have 2 randomizations, so pre versus post-op, and a higher versus a standard dose of radiotherapy. The local failure risk is based on what they call the modified Oberlin score. A score of 2 or above gives you a higher local failure risk, which is what that's based on. The radiotherapy in metastatic disease is a relatively controversial topic. In essence, the conventional wisdom has been to try and give as much radiotherapy, so the prescription dose to the primary should be 50.4 Gray, and in essence, the aim is to try and give as much radiotherapy to as many of the metastases as is physically achievable. There's no randomized data to that. It's what the IRS IV study did, so it's what we have tried to adopt. But again, there's obviously an important debate between the morbidity and efficacy of therapy. So again, can lead to quite difficult discussions between what you think is genuinely doable and achievable. That's one of the questions that FARMS will attempt to address. So it will look at patients with favourable metastatic disease will get the standard of care, which is radiotherapy to all the sites that you can get away with treating. Those with unfavourable metastatic disease, that's a high Oberlin score of 2 or above, will be randomised to either radiotherapy or no radiotherapy. So the hope is that this will give us prospectively randomised data to quantify the benefit of radiotherapy for extensive metastatic disease. A question which is currently unanswered, other than the single-arm IRS IV study. But again, that was a non-randomised study. This is a sort of example of what we mean. This is a child who had metastatic rhabdo, who had an intra-abdominal primary, and then had multiple lung metastases. And this is a radiotherapy plan, again, looking at significantly higher doses of radiotherapy. So the area that you can see on the axial images where there's the sort of a dark red colour, that's the 50 Gray isodose, and then the areas in blue above is the 20, on the lungs is the 20 Gray isodose. So we're giving a significantly higher dose of radiotherapy to a fairly significant volume of this young person. So again, we don't have randomised evidence to back that up, but it is what was done in IRS IV, which has become the gold standard for radiotherapy in metastatic rhabdos. The brief messages in terms of take-home messages with rhabdo are Generally, no role for radiotherapy in completely resected stage 1 embryonal disease. We don't see very many of them. Those with stage 2 or 3 disease should have risk stratified treatment. Stage 4 disease is a grey area, but in essence, we treat the current EPSSG protocols to treat where technically deliverable with an acceptable toxicity profile. How you define that is challenging and is subject to inter-user variability. But there's no indication for higher dose or hypofractionated radiotherapy, and again, maybe. I'll maybe need to quite quickly skip through the medulloblasts. I'm conscious that we're taking up lots of your time already. But in essence, for standard risk medulloblastoma, again, I'm sure you'll have lots of detailed talks about risk stratification in medullos. The CCG 9892 study established the current dose and regime that we use for standard risk medulloblastoma. So historically, we used to use high dose craniospinal for all medulloblastoma cases. The CCG 9892 study gave a reduced dose of craniospinal radiation alongside adjuvant CCNU vincristine. So by reducing the dose of radiotherapy, we were able to reduce late neurocognitive effect without compromising outcome. The challenge is that that study mandated starting within 31 days of surgery, which, given that craniospinal radiotherapy is our most complex radiotherapy technique, that's quite a big ask. But we aspire to do so. And again, the boost to the resection bed, even though we reduced the dose to the total craniospinal axis, the dose to the tumor bed stayed the same. And currently, standard risk medullo is an eligibility criteria for proton funding. But as I'm sure you can imagine, to have an operation and be referred to the Christie and get down there and treated within 31 days is a big ask. So that's one of the factors that plays into travel. I won't go into too much detail. Suffice to say that we now treat smaller volumes than we used to for medulloblastoma. And again, this is just the schema. You'll have the slides. You probably don't need to go into much detail. But children with high-risk medulloblastoma get treated as per the St. Jude's protocol now. It used to be the Milan protocol until late data showed an increase in neurocognitive toxicity. So they now get St. Jude's with high-dose craniospinal radiotherapy up front, which involves either 36 or 39 gray to the craniospinal axis, and then boosts to primary site and metastases. Currently not eligible for proton funding in the UK. The controversy is that from a radiotherapy perspective, they probably have a greater chance to benefit than the standard risk patients, but the rationale for the funding being that their survival is significantly worse, so the reduction in late toxicity is not sadly felt to be of overall benefit, as controversial as that currently is. That may well change in the coming years, but at the moment they are currently not eligible for proton beam funding in the UK. I won't go into this in too much detail. This is very boringly technical radiotherapy. In essence, all you really need to know is that craniospinal radiotherapy is probably the most complicated technique that we do. In essence, because you have to match 4 or 5 different radiotherapy fields to a child who's hopefully lying nice and still, and who will need to do for around about an hour of treatment. There are also a number, because of the volume that we treat, a number of organs that get in the way that we have to think about. So again, I won't go into that much detail. Again, this likewise just shows a child that we have treated. The image on the left shows them, or all of them are them in the sagittal plane. Image on the left shows the number of fields that we use for radiotherapy, which in this trial totaled 13. Most standard radiotherapy treatments use 1 or 2. The image in the middle shows all the areas of the child that receive any dose of radiation, and the image on the right shows those that are receiving a moderate to high dose, so that's above 30 gray. The red areas and the green areas are a higher dose, the blue areas are almost exactly 30 gray. So as you can see, a significant burden of radiotherapy for, in this case, what's a pretty little person. The price of that, sadly, is of late morbidity. Again, things that you'll be used to seeing in longer term follow-up clinics, particularly neurocognitive, secondary malignancy, vascular and pituitary hypothalamic dysfunction, amongst many others. The thing that we probably think the most about, or the biggest concern for us as radiotherapists, often is the neurocognitive effects in young children. This is a paper that Tom Merchant presented 5 or 6 years ago now, looking at the IQ, and I accept IQ is a relatively crude score of neurocognitive function, but looking at the IQ score in children treated under the age of 4. So that sort of dotted line that's on the upward trajectory shows the projected IQ in children that have not had radiotherapy. The line at the bottom, the solid black line, is those that have craniospinal radiotherapy, and then the one that's in between the two is those that have just had local radiotherapy. So you can see that any radiotherapy has a significant detriment on neurocognitive function, particularly craniospinal axis treatment, as you can see from that previous sagittal picture, because of the amount of the brain and the amount of the child that we sadly have to treat. The other thing that we think about, particularly focus on, is radiation-induced secondary malignancy. Again, all we really need to know is that it is dose dependent, and the 30 gray craniospinal dose has an odds ratio for increased risk of glioma of just under 7 times, and nearly 10 times risk of meningioma compared to the background population. So there is a significant lifetime increased risk of secondary malignancy. Again, radiotherapy is it's an effective treatment for children with medulloblastoma in terms of maintaining outcome, but sadly is associated with critical late effects that do have an impact on children as they grow up, and sadly really for the rest of their lives. There are attempts to try and defer or potentially avoid radiotherapy in infantile medulloblastomas, really because of the morbidity of treating the under 2s particularly, which is the Head Start protocol. I'm sure you're all very aware of, and the hope in the Head Start protocol allows, if they have a complete response after high dose, potentially to avoid radiotherapy, and then the role of proton beam therapy in reducing late morbidity, but we actually have very little evidence to guide patient selection for protons. We'll touch very quickly on protons again, because it is a separate talk all into itself that could go on for even longer. As I'm sure you're aware, we deliver X-rays. So the picture on the left is what's called a depth dose chart. So in essence, the y-axis is incrementally increasing radiation doses. The x-axis is tissues as the beam of treatment traverses through a child. So on the left-hand side, you start at the skin, you're then into subcutaneous tissues. The sort of shady grey areas where the tumour sits, and then the deep tissues are things beyond the tumour. The red line at the top is the behaviour pattern of attenuation of a photon of radiotherapy. So as you can see, it hits the skin. There's a relative skin sparing effect. The dose then increases underneath the skin and then gradually drops off over time or over distance travelled. Conversely, if you compare that to the white curve underneath with the dotted blue line, that's what's called the Bragg peak of a proton. So a heavy particle that can be specifically designed to deliver the dose of radiotherapy, which then suddenly, fairly abruptly stops before it reaches those deep tissues. So it allows an ability to reduce the amount of the body getting a low dose of radiation treatment. The high dose of radiation treatment is exactly the same. So there's no in structures that lie within that high dose area, but protons can spare low dose areas of the brain. And on the right hand side, what you can see are 2 images. So the one on the left of those 2 images is the same child with a proton beam plan. You can see the structures in the front of their face in terms of mandible, nasopharynx, nasal cavity, all get pretty much no dose of the radiation treatment. Whereas the one on the right is what's called an IMRT, so a photon radiotherapy plan, where you can see those structures get on average between 5 and 10 gray of radiation treatment. There is very little data, so that's obviously dosimetric data. There is very little evidence base to show that that has a clinical tangible benefit. The lack of exit dose is anticipated to reduce some late effects by reducing the low dose spread of radiotherapy treatment. The only studies there are for that are single institution retrospective series. There's no randomized evidence to show a definitive reduction in late morbidity, but we do know they have equivalent disease control. So children are no more likely to be cured by protons or to have local control by protons, but there's some dosimetric data that suggests they may have slightly reduced some late toxicities. but those would only be to structures that sit out with the high dose area. Those that sit within the high dose area would have the same late toxicities. One COG study that Danny and Delicato presented last year did demonstrate actually a lifelong cost benefit with protons due to decrease in some late effects. But again, that was retrospective, fairly highly selected patient group. So again, there's a significant element of bias amongst it. The challenge of the protons are that there's no randomized studies showing the benefits or not of proton beam therapy. Accessing it in a timely manner, particularly for treatments like medulloblastoma, Wilms tumours, is very challenging, involves coordinating with different centres, logistical challenges of family of travel, and there are some setup uncertainties with proton beam therapy, which we won't go into too much detail about, but it's really for the proton centres to worry about. And this reflects that. So this is what's got a dose volume histogram. So this is the deposition of radiotherapy dose by a single proton beam. Amongst each of those colours is a different patient. So there's 11 of them. And in essence, what this reflects is that the dose of the radiation treatment for each of those patients could lie anywhere within any one of those sort of shaded pencil grey lines in between. So there's what's called a range uncertainty with protons, where if it traverses over an airspace or a bone density or something as simple as an NG tube or something that wasn't there when they had the planning scan, that shows the uncertainty of where the dose would be. So there can be a nearly 60 to 70% uncertainty of where your dose is deposited. So again, that's something that the proton centres are used to familiar with, but it's one of the things that we have to think about with proton therapy that you don't quite in the same way have to think of with photon therapy. Again, I'm sure you're all used to this. This is the current UK indications for proton funding. One of the key things that doesn't necessarily mean that protons is definitely the best treatment for that child. We have to take into account other factors of psychosocial factors, travel, ability, fitness, various things in terms of the priority of reducing late morbidity, but certainly these are indications that would be approved for funding. So if it was felt to be clinically appropriate, these are the tumours that would be felt likely to be approved by the proton panel in the non-metastatic state. So things like the rhabdomyosapendymomas, Ewing's, it would only be localised disease currently, although that is not. It is under review because some rhabdos with small volume metastases in the very young may be accepted on an individual basis. The take-home points, just to rattle through the last bit, I don't want to keep you too much longer, about protons. There are some dosimetric advantages that may facilitate a slight reduction in late morbidity. There's no difference in local control or disease-related outcomes, and we always have to balance the pros and cons of potential reduction in late morbidity for each individual, which is why it's never entirely straightforward and is always a very individual discussion with children and their families. I think that's the last thing. I had any particular questions, so I had to rattle through the last bit. I don't want to keep you too much longer. Any immediate questions, anything anyone thought of?
Thanks very much for a really excellent talk, Ben. I'll give about 30 seconds to see if anybody types any other questions in. That was a really interesting, and thanks for you summarised so many different tumours that where radiotherapy is used really nicely. It's quite difficult, I think, to fit all of that into a talk, so I appreciate that. I guess just one question from me is just about, so obviously we're talking about an infant medulloblastoma, the IQ quite heavily affected in under 4-year-olds. Is there any evidence to say that the IQ is less impacted if you're a bit older than that, or is that's just not been able to be studied? In terms of is it just in under 4s, or does it continue to affect your IQ quite significantly even after that? Is there evidence for that as well?
Yeah, so there is such, and we look at the Milan protocol, which is what used to be used in the UK and in the CEOP group before we adopted the St Jude's protocol. The Milan protocol also treated adults. So actually, it did show that there is a late neurocognitive effect even in adults treated with medulloblastoma. So your adult IQ, if you're treated after the age of 30 for medulloblastoma, your IQ within 15 years is estimated to be on average about 20 points less than if you'd never had radiotherapy on a basis of compared to population background. So again, there's no randomized evidence, but there's no doubt that it does have a detriment whatever age you're treated, but just that the severity of it is higher the younger that you're treated. Again, it used to be that the cutoff used to always be 3 years old for craniospinal radiotherapy. That's now crept down to 2 in recent years, in part to look at can we improve outcomes, particularly high-risk medulloblastoma children. But no, sadly, the risk is there whatever age you are. It's just a greater risk the younger you are, unfortunately.
Thank you very much. And the other thing I wanted to just ask about is, like, in terms, proton beam therapy seems to have like basically been gaining a lot of traction more and more recently, and it's been on the news and everything like that. So I just wondered from a kind of personal perspective yourself, are you finding more and more families are asking you about proton beam therapy? And if yes, in terms of kind of discussing and answering that with them, do you have to kind of go back to where the evidence base is to kind of approach that situation?
You know, it is really hard, in all honesty, because and it reflects a lot of radiotherapy technologies, because the evolution from static field 3D conformal radiotherapy through IMRT through VMATs, the technologies that we use for photon treatments, studies can't really keep up with the change in technology. So most studies from inception to design to recruitment take somewhere in the region of 5 to 10 years. Even as a single center, we have had 4 revisions of our VMAT delivery technique in the past 6 years. So it is very hard for studies to keep up with the technology. So we're sort of used to that from a radiotherapy perspective, that we rarely have good evidence that dosimetric advantages, so reducing the dose on a computer algorithm, does that actually correlate to a better outcome for a child? And the honest answer with protons is there is no evidence really, or there's no good evidence. The retrospective series there are in extremely highly selected patients, because those are the ones that currently meet the indication criteria, and by the nature of that is they are the ones that have a better prognosis. So it is very, very difficult, and there are certainly an increasing number of patients that do ask us about protons, in adults and in children, because I think it does create more traction now that it is in the UK, but it is very difficult. We had a couple that we have a lot of talks with the Christie and with the proton centres about, and discuss what their thoughts of the benefits are, what our thoughts of the benefits are, and have a couple that have actually then gone away from protons because actually they felt it may be inferior in one of them. So the honest answer, it is really, really difficult, and it's difficult even looking at a scan to try and quantify the proton benefit. It's a big implication for families, to especially going abroad, in terms of taking them away from their support network, the team that know them, travel, everything that comes with it, for an uncertain advantage. So it's a difficult conversation, to be honest.
Yeah, absolutely. Thanks very much. That's really helpful.
Yeah.
I think that highlights why we have to discuss this quite a lot at MDTs as well, because it's not a straightforward answer every time.
Yeah, absolutely. And there's always that debate. There's the things that are on the list, so that's the funding list of things that are likely to be approved. But yeah, you're right, that doesn't always mean that's the best treatment for that child. It just means that they are, if you're not on the list, then the panel are very likely to say no. But it doesn't mean that because it's on the list, it's definitely the right treatment. But it's always got to be an individual.
That's great. Thanks very much, Ben. I don't think there's any other questions coming through, but we've recorded the whole session. It was really good. So it'll be available on the MSN Children and Young People with Cancer YouTube page as well, for anyone that wants to kind of pass this talk on to others. The only last thing to just say is thanks again to Ben for speaking, and thanks to everyone else for joining in today. I've just put a little link in the chat, which is just a SurveyMonkey. It's just a few questions just to try and see ways to improve the kind of online teaching platform, and your responses would be much appreciated. So yeah, just thanks again, Ben. I think we'd all be really looking forward to future chats on the kind of radionuclide therapy as well, and MIBGs, etc. I think that'd be really good too.
Yeah, and I'm conscious that radiotherapy today is an awful lot to shoehorn into it, so apologies it took us a bit longer. But yeah, certainly if there are other radiotherapy questions or things that you want us to focus on in a more concise fashion, very happy to do so.
That's great, thanks. And sorry, last wee thing, Julie Mackay just put the hand up. I don't know if that was intentional or not.
Sorry, no.
No
Thank
worries.
you though.
Okay. Right, thank you so much. Okay. Cheers then.
See you later. Bye.
Thank you. Bye-bye.